Very good afternoon to one and all. I am Arpita from the IGCP group. Welcomes you all to the new session on the topic Cancer Cervix Target Delineation for Radiotherapy. Now we have with us Dr. Chittaranjan Kundu sir to give his expert comment on this topic. Sir is an MD in radiation oncology. He is a senior consultant at the Mahatma Gandhi Cancer Hospital and Research Institute, postgraduate institution of oncology at Visakhapatnam. So now I would request Sir to please start with his talk. Over to you, sir. Please start, sir.
Hi everyone, this is Dr. Chittaranjan Kundu, radiation oncologist from Mahatma Gandhi Cancer Hospital and Research Institute, Visakhapatnam. I'll be talking on cancer service, and after a brief discussion, I will talk about different aspects of contouring for radiotherapy. My contouring will be restricted today for external beam radiotherapy only. Female genital tract consists of uterus and its appendages and vagina. Uterus consists of upper fundus part, middle body, and lower narrow cervical part. Cervix is continued downwards as a vagina. The uterine appendages consist of fallopian tubes and ovary. Blood supply to the uterus is mainly through the uterine artery, a branch of internal iliac artery, and ovarian artery supplies the ovary. A branch from the uterine artery that is called vaginal branch supplies the vaginal part of the female genital tract. As disease progresses, more and more lymphatic nodes get involved. So here we can see the lymphatic images of lymphatic drainage of the uterus and vagina. The upper part mainly drains into the aortic and superficial inguinal nodes. Middle part drains into external iliac nodes, and lower part drains into the sacral lymph nodes and also external iliac lymph nodes. Lymphatic drainage has got clinical importance. Roughly, as the stage progresses, so more and more lymphatic stations get involved. We can call it roughly rule of 15. Means in when the disease is in stage 1, 15% of pelvic lymph nodes get involved, and the overall survival is around 85%. When it is in stage 2B, nearly 30% of pelvic lymph nodes get involved, and the overall survival decreases to 66%. And in stage 3, the pelvic lymph nodal involvement is around 45%, while overall survival decreases to 40. And in stage 4A, it is 60% and overall survival decreases to 22. And in stage 4B, it is 9 only. So lymphatic drainage has got importance in cervical cancer. So cervix basically is the lower narrow end of the uterus that connects uterus with the vaginal part. It has got two parts. One is ectocervix and another is endocervix. The ectocervix is covered by squamous cell epithelium, and endocervix is covered by columnar epithelium. So where the both epithelium meets, we call it as squamo-columnar junction, and metaplasia becomes more pronounced at this junction, and cervical cancer arises from here and spread outwards to ectocervix and to different parts as the disease progresses. In the era of 2D radiotherapy, lymphatic trapezoid was used to calculate radiation dosage to different points. But nowadays, as technology has advanced a lot. So lymphatic trapezoid is hardly used nowadays. The upper point is called the right and left paratic nodal point. Middle point is known as the right common iliac and left common iliac, and lower point is known as the right external iliac and left external iliac. HPV infection is one of the most common cause of the cervical cancer, and added to it, low socioeconomic status, increased variety of the person, male partner with history of multiple sexual partner, and male partner with also penile cancer, sexually transmitted disease, smoking, multiple sexual partners, young age at first intercourse, and decreased immunity with nutritional factor. These all added to the risk of developing cervical cancer. As disease progresses, normal cervical epithelium converted to in cervical intravitreal neoplasia, 1 cervical intravitreal neoplasia, 2 cervical intravitreal neoplasia, 3, and then it progresses to cervical cancer. So during the process of progression, normal cell to CIN1, then to CIN2, most of them get recovered, and hardly few patients develop cervical cancer. So the average time of transformation from CIN to carcinoma cervix is around 10 to 12 years. This picture depicts how HPV virus get inside to the basal cell of the epithelium. So in the epithelial cell, it it is multiplies in many numbers, and it tries to insert its own genome into the epithelial genome. So in the process, 90% kill within 2 years of the infection. But if infection persists thereafter also, then viral genome dictates the tumor genome, and it proliferates unhindered and ultimately develops carcinoma cervix. So almost 96% of the cervical cancer, as nowadays evinced, it is caused by HPV or human papillomavirus infection. Different strains I told, mainly strain 16 and 18. HPV genome integrates into the epithelial cells, and it liberates two proteins, that is E6 and E7. E6 inactivates P53, which causes chromosomal instability, inhibits apoptosis, and activates telomerase activity. And E7 affects retinoblastogen. So all this leads to the uninterrupted proliferation of the cervical epithelial cells, and ultimately developed into cervical carcinoma. This is clearly demonstrated here. This is the cell cycle G1 S G2M. So in the G2 checkpoint, it is highlighted. Two scenario is here: HPV not present and HPV present. When HPV not present, the defective DNA is taken care of by P53 gene, and so it proliferates normally, and cervix remains healthy. But when HPV infection is present, the P53 protein is deactivated by the P53 inhibitor that is derived from the HPV virus, and the deactivated cervix cells then mutated and successfully divides, and it ultimately leads to the formation of the cancer cervix. Carcinoma staging, it is FIGO 2023. It is a pictorial demonstration. We can grossly tell it is cervical cancer 1, cervical cancer 2, stage 3, and stage 4. When it is confined within the cervix, it is staged as stage 1A. It is again divided into 1A, 1B, then 1A, B1, B2, B3 is there. Then when it goes beyond the cervix and involves the not up to vagina but not up to lower one third, and involves the parametrium not up to pelvic wall, it is stage 2B, sorry, stage 2. Then when it goes beyond that and involves up to lower part of the vagina, or it involves the pelvic side wall, or it produces non-functional kidney or hydroureter nephrosis, then it is stage 3. Then when it spills beyond the true pelvis and involves the adjacent organs like bladder anteriorly and rectum posteriorly or to distant metastasis, it is stage 4. This is TNM staging with FIGO staging side by side. Only the change part is highlighted in the red rectangles. T1A as is FIGO 1A. It is divided into 1A1 and 1 into. It is based on stromal invasion less than 5 millimeter. When the stromal invasion less than 3 millimeter, it is stage A1, and when it is less than 3 millimeter and also not reaching up to 5, then it is stage 1A2. Similarly, in stage 1B, it is divided into stage 1 B1, B2, and B3, where in all, like I said, deepest invasion is more than or equal to 5 millimeter, but stage 1 B3, where the tumor size is more than 4 centimeter. Coming to stage 3, C is incorporated and C is divided into C1 and C2 depending on the nodal involvement. When the node is inside the pelvic cavity, it is C1. When it is other nodes are involved like paraortic, it is C2, 3C2. This is irrespective of the tumor size and other involvement criteria. Before going to radiotherapy planning, I want to mention here that up to stage 1 and stage 2A1, treatment is mainly surgery, followed by, according to the histopathology, we take it for radiotherapy. And from stage 2B to stage 4A, the planning is mainly concurrent radiotherapy. So we'll be discussing radiotherapy planning from stage 2B to stage 4A, otherwise, how to contour different parts, how to contour target balloons, how to contour the lymphatic areas. So, having diagnosed the patient as a CS cervix, and on doing the staging, we have taken it for chemoradiotherapy. Then before going to it, we make a mold of the patient, we prepare, and then we call the patient for CT simulation. For CT simulation, we follow some guidelines. The guidelines are like this: we keep the patient fasting for minimum of 4 hours, and on the morning of the CT simulation, we give the enema to empty the rectum. Then we call the patient and ask him to ask her to drink water, 500 to 700 ml water, and to wait for half an hour. It should be bladder for bladder filling disease, and it should be within the comfort level of the patient. Then we take the patient to the uh, CT couch. We make the We position the patient in supine position, secure the IV line, we give rectal contrast, and then one knee wedge is used for positioning to maintain position reproducibility. Then CT scan is obtained from T10 to 11 level to up to upper third of the femur with a slice thickness of 3.75 millimeter. Nowadays, MRI is taken as the gold standard for both external beam radiotherapy and brachytherapy. MRI, if it is possible, will take it in a treatment positions. In that case, we have to follow same protocol as CT planning. But if MRI planning is not available and diagnostic MRI is available, we can still use that images. So T2 image is mainly useful for us for contouring. Target volumes we use is as per ICRU 50, 62 or 83 guidelines. GTV is gross tumor volume at diagnosis. That is, we find by clinical examinations, by radiological examinations, we delineate it on a planning city as well as we make a note of it, do a diagram of it. Then we draw the CTV. CTV is the clinical target volume. It is GTV plus suspected microscopic tumor extension. ITV is given to compensate for internal motions of the organs, and above all this, we give VTV to compensate for setup margins. How to draw different target volumes? So the diagram shows the GTV T, then GTV, CTV T, and then CTV LR, CTV H, HR, and CTV LR. GTV T is defined as contour basic on imaging data, that is from the planning city, from the PET planning if it is available, and from the MRI. The subgroups of GTVs are initial GTVT initial, GTVT HR, and GTVT LR. This is all as per GES Astro guidelines. So in the next diagram, it is elaborated. This is hatched red, shows the GTVT initial. Then this shows the HR CTVT initial, and this is LR CTVT initial. I will tell later what are the parts to be included in these target volumes. So GTVT initial, it is if MRI is available, it is better to control there and then to fuse with planning city. T2 weighted MRI is where it appears as a hypo intense. So it is controlled there in red. This is the GTVT initial. CTVT HR initial is controlled taking into GTVT initial plus rest of the cervix that is not infiltrated by the tumor. So that becomes CTVT initial, CTVT HR initial. Then we'll discuss about this CTVT LR or low risk CTVT. The here we include the CTVT HR or high risk CTVT that we have drawn earlier. It will be included in it. The complete uterus, the whole of parametrium bilaterally, uninvolved vagina with 20 milliliter margin, and CTVT HR plus will give some margin here anteriorly 5 millimeter and posteriorly towards rectum 5 millimeter will give margin, and in case of involvement of the pelvic wall, sacro-uterine ligaments and mesorectal or other involved structures are also taken into consideration, and here we give 20 millimeter margin as the case indicated. This is CTVT HR initial controlled in magenta. CTVT low risk initial, already told. This is ITB. ITB, as I told earlier, ITB is given to compensate for the organ motion, internal organ motions, and it is given at CTVT, ITVT LR with 10 millimeter margin. We give all around. We give uh, craniocaudally and posterior inferiorly, that is 10 millimeter, and laterally it is given 5 millimeter. But caudal margin is kept at the CTVT LR, so it is not extended beyond that if it is not involved by disease. So this is ITVT LR. Parametrium is a tissue around the cervix. So we have to delineate the parametrium entirely. We take posterior border of the bladder and posterior boundary of external iliac vessels. Posteriorly, it is the mesorectal fascia, and laterally, the pelvic side wall. Superiorly, the fallopian tube, the uterine vessels, and broad ligament. So, inferiorly, it is the urogenital diaphragm. So, it is the ITB. Sorry, it is the parametrial definition and guideline. This is summarizing the MRIs to contouring guidelines. When there are two scenarios: when diagnostic MRI is available and when MRI in treatment positions. So that when diagnostic MRI is available, we cannot match it bone to bone. So we'll try to match soft tissues, and we can contour GTVT and CTVT HR with MRI and then fuse it. Then with the planning CT, we'll contour rest of the parts up to PTB and organs at risk. When MRI in treatment position is available, we can contour GTVT, CTVT HR, and CTVT LR in MRI, and then we can fuse it. The fusion is better when MRI is in treatment positions. And nodal contours, GTB node, CTBE, that is prophylactic nodal volumes, and CTBN, all can be either can be drawn in MRI or can be drawn in planning CT. Organet is preferably drawn with the MRI images. The rest of the volumes, that is ITVT LR or ITV 45, and then PT 45 is drawn on planning CT scan. MRES2 advocates to keep the external beam radiation restricted to within 45 days. So we have planned the dose. We plan the dose schedule accordingly. So 45 is the prescribed dose, 28 fractions, one fraction per day, 5 days in a week over 5 weeks, and then we reassess for brachytherapy. If there is any treatment break for more than 2 consecutive treatment breaks, we treat daily 2 fractions of EBRT, which should be more than 6 hours apart. So maximum overall treatment time should not exceed 50 days, including both external and brachytherapy. PTB 45, at least the criteria is that at least 95% of the volume should receive 95% of the prescribed dose of the, that is 45 gray, and maximum dose we allow for 107% of the prescribed dose. So if grossly node is involved, we control the node and we have to give boost to the node. So, but we keep the treatment duration within 45 days. Sorry, within 25 fractions, uh, and we devise our dose fractionation like that. When the node is inside the true pelvis, the external beam dose in we treat it by simultaneous integrated boost. So 2.2 gray per fraction we give, that becomes 55 gray. And when giving the brachytherapy, as the uh, node is inside the pelvis, some dose it receives from the brachytherapy procedure, and that is around 3 to 4 gray equity to, and total it becomes 60 gray equity and the total uh, duration is kept within the our limit. But when the nodal involvement is outside the true pelvis, then we revise the dose each fraction 2.3 gray into 28 fractions, so it becomes 57.5 gray, and equid2 it becomes 59 gray. So brachytherapy dose in the brachytherapy dose in this case is very negligible for the nodal volumes. So it two doses almost come to 60 gray. This is this nodal volumes CTB1 and other volumes like CTB2 and CTB3 is as per PGI contouring guidelines. So pelvic lymph nodes is contoured starting from the L4 L5 interspace. The vessels are drawn from the L4 L5 interspace, common from aortic bifurcation, then common iliac arteries on both sides, then common iliac artery divides into external iliac artery and internal iliac arteries, then internal iliac arteries are divides in the obturator and the sacral vessels. So we we draw the vessels, then we give margin of around 10 millimeter to make it CTB nodal or CTB1. Obturator area is taken with a 17 millimeter strip along the lateral pelvic wall from the side of the cervix. GTB2 is the primary tumor. This is entire uterus with cervix, then parametrium and vagina. This is CTB2, and CTB3 is the entire parametrium. Cranially, from where true pelvis begins, anteriorly posterior border of bladder, and posteriorly, if it is less than stage 3B, then it covers up to the major rectum. But if when it more than stage 3B, then the entire major rectum has to be included in the CTV3. IT margin is given, as I told earlier, to compensate for the internal organ movement. This is because of some variable occurs during bladder filling, and also sometimes because of rectal filling. Some variation occurs, so we give some IT margins. Then IT margin actually given on CTB2 with expansion of 15 millimeter anteroposteriorly, 15 millimeter superiorly, and 7 millimeter laterally from the uterus, or from it includes uterus, cervix, that is CTB2. So total PTB is drawn like this: CTB1 and CTB2 and 3 we give 10 millimeter margin. Then we give CTB2 15 millimeter margin to form ITB. Then the entire thing is joined to make it PTB 45. The next diagram will show it clearly. So this is the CTB2, uterus, cervix, etc. And this we are giving margin of 15 millimeter, so it becomes IT for the uterus. This is the nodal volumes, and when we give margin uh, to these 10 millimeter margins and we include the ITB, it becomes the PTB 45. Taylor pelvic down contouring guidelines is also in the similar line, starting from the aortic bifurcation to common iliac artery, then to external iliac and internal iliac nodes, and to include the presacral nodes. So this shows external iliac medial, external iliac anterior, then external these two combine to make it external iliac 1, and this is PM is presacral and OB is obturator nodes. So this is how we draw the nodal volumes as per our Taylor guidelines. In case of post-op settings, sometimes in early stage of disease, patient is treated by surgery. Then after evaluation of the biopsy reports, we found that patient actually need external beam radiotherapy. So in that case, we have to control uh, the different target volumes, and we have to treat it with external beam radiation. So the target volumes in case of post-op cervical cancer, it is the draining lymph nodes like common iliac lymph node, external iliac lymph nodes, internal iliac lymph nodes, and parametrium, upper vagina, presacral, and as like others, ITB also given to take care of bladder filling variation. Presacral, I want to mention here that presacral, if cervical stroma invasion is there, then only we need to draw the presacral area. And rectal filling, there is no consensus regarding the rectal filling guideline. But if rectum is overloaded when we are planning, then we should think of replanning. These are the some of the contours. It starts from the aortic bifurcation, common iliac lymph nodes, then coming down to internal iliac, then external iliac, then obturator and presacral. These are presacral nodes and parametrial nodes. This picture shows the parametrial or vaginal clinical target volume. Having controlling everything, all the target volumes, now we need to control the normal organs, that is called organ at risk, because those prescription need to be restricted there also to avoid the long-term complications of cystitis or proctitis. So what are the organs that we need to draw? That is bladder, rectum, sigmoid, small intestines, and femoral heads. So these these things is contoured in preferably in the MRI if it is available. Otherwise, we will contour it on the planning sitting. So upper part like a kidney or spinal cord is drawn if we take paraortic lymph node area into irradiation area. Then ovary is contoured in case of there is a ovarian transmission is there. So those constants of the wires is depicted in this table. So in case of bowel, B40 gray should be less than 100 cubic centimeter when no lymph node boost is given, and B30 gray should be less than 350 cubic centimeter. But when lymph node boost is given or paraortic irradiation is there, we can go up to B40 grade to less than 250 cubic centimeter and B30 to less than 500 cubic centimeter, and Dmax remaining at 57.5 gray or less. Similarly, sigmoid colon, we need to be restricted within 57.5 gray. Bladder, there is a guidelines, B40 gray should be less than 75% of the dose volume, and V30 gray should be less than 85% of the volume, and Dmax is less than 57.5 gray. Rectum also, similar guideline exists for B40 gray, less than 85% of the volume should receive, and B30 gray should be received by less than 95% of the volume, and Dmax remaining less than 57.5 gray. Spinal cord Dmax is kept with less than 848 gray, and femoral head Dmax less than 50 gray. Kidney, for kidney, Dmin should be less than 15 gray. So these are the OAR guidelines while treating the patient with SIB. So thank you very much.
Thank you, sir. Thank you so much for the beautiful presentation. Sir, now it's time to take some questions from the audiences. Shall we go ahead, sir?
Actually, sound not audible from your side. Maybe there is disturbance in the atmosphere. Weather disturbance.
So is it audible now? Hello, hello, sir. Am I audible to you? Sir, am I audible to you now? Sir, am I audible to you now? Hello, sir. Am I audible?
Sir, am I audible now? Hello, sir. Hello.
Madam, sound is coming breaking, not audible.
Not at all audible, sir. Sir, I will post the questions in the comment box. Hello. Sir, just give me 1 minute. 1 minute, sir. 1 minute. Sir, am I audible now?
Hello, hello,
Sir, am I?
hello.
Sir, am I still not audible?
Yeah, now you are audible to me in the mobile. It is actually on screen. It is not audible.
Sir, now also not audible.
Hello. Yeah, I'll leave the meeting. Huh? Okay, okay, okay.
Hello, sir. Am I audible to you?
Yes,
Am I clearly audible now, sir? Hello?
hello.
Yeah, sir, am I clearly audible to you?
I can hear you with the broken voice.
Okay. Sir, I will put the questions
Can
in
you
the
hear me?
comment. Yes, sir, I can hear you. I can hear you clearly, sir. Sir, can we take the questions? We'll take one or two questions only and conclude the session. Hello? Okay, sir, no problem. Sir, let us not take the questions then if
Yes,
my voice is not. Hello? So, anyway, sir, thank you, sir. Thank you so much for giving us your precious time. And since there is maybe some technical issue or something and my voice is not audible to you, so we would like to conclude the session here. Thank you so much for your time. Thank you, sir. Thank you, sir. We are closing the session now.